should have done that. But we are recording now, so
Should we share my screen so they can see the slides, or do they somehow already see the slides?
that we should share your screen, so let me. I think that's ready to go.
Great.
No?
Good.
Perfect.
Great, thanks so much, Byron, for the introduction. I'm so happy to be here presenting. And I apologize, I was supposed to present in the fall and I ended up having to reschedule. And so I really appreciate Leo, Byron, everyone for figuring out how to squeeze me in this semester. So the title of my talk is The Need to Prioritize Patient-Centered Care and Accountability of Inpatient Psychiatry. So I'm going to be presenting a specific study, but it's going to take a little while until I arrive at that study. So I'm going to spend a good while going over background, and we'll be presenting some of my descriptive work that really has motivated the study that I'll then be presenting. And then that study is motivating my next steps with my research program. So I'll try to explain that all to you. So the agenda is pretty simple. So I'll go over the background, and then I'll present this one study on patient-centered care, and then I'll go over next steps. So my talk is going to include discussion related to abuse, restraint, and seclusion. I just want to give everyone a heads up. I'm mostly going to be talking about numbers. So the information of the data isn't necessarily very emotionally charged in that sense, but there are 3 quotes that might be a bit upsetting, and they occur earlier in the presentation. So if anyone wants to leave, I won't be offended. Just want you to be forewarned. And then I want to also just orient everyone to what my positionality is of my research. So this isn't going to be a classic positionality statement in terms of like my identities per se, but as a health services and policy researcher, what I decide are the outcomes that I focus on is heavily influenced by what my values are, what the values of my institutions that I engage with are, et cetera. So I just want to be clear that for me, I like to use the Institute of Medicine's framework for quality of care to think about values. And my work is very focused on patient-centeredness specifically, equity, and a little bit of safety. So I'm interested in identifying evidence that advances those outcomes specifically. Okay, so some background. So what is inpatient psychiatry? So we're not really monitoring the chat, so I'll ask folks in the room. What is it? Anything. What happens inside of psych facilities? Yep.
I'm pretty sure a lot of psych facilities are locked, but it gives the patient time to be away from what's outside the world and focus on themselves without like the distraction of technologies and schoolwork.
Okay. So the unique function of a psych facility is that it's a place away from home, away from their typical distractions, and a place where they can focus on themselves. Yes. Anyone else? Yes, Leo.
You stay overnight or for multiple days?
Yes. Yeah. So inpatient psychiatry, so there is a formal definition for inpatient psychiatry, which is useful to understand when it comes to doing research on this. So inpatient psych typically is, it is an inpatient, it's a setting away from home, yes. May or may not be locked doors. You spend the night, typically it's short stay, so less than a month. Some folks might spend longer, but they're kind of a rare case. And importantly, inpatient psych is not the same thing as residential. And it matters because it means that inpatient psych is a hospital-based service, so it falls under the purview of, for example, the CMS's regulations for hospitals. So when we're thinking about accountability, understanding what is considered a psych facility versus not is important. And then when it comes to what actually happens inside of a psych facility, we don't really know. So it's actually a black box. We have some sense for what might happen, but for example, we don't know, how typical is it that a patient receives one-on-one psychotherapy, right? I think probably that's not very common, but that's just based off of my conversations and interviews with patients. There is no systematic data on this. We don't know how long patients typically spend with psychiatrists. We don't know, to what degree there are evidence-based treatments are being provided within psych facilities, what is happening in these group therapy sessions, et cetera. So inpatient psych is really a black box. And what we do know about it is not rosy, right? So there's a lack of evidence for the benefits of inpatient psychiatry as an intervention. There have been comparative randomized control trials since the 1950s, comparing inpatient psych to lower level intensive outpatient treatment settings. And for those patients that are on the margins who could be randomized to go into inpatient versus an intensive outpatient setting, we don't see that inpatient psych provides any advantage. And in fact, on some indicators performs worse, specifically social indicators in patient satisfaction with care. Recent discharge from inpatient psychiatry is one of the strongest predictors of suicide. The rates of suicide are astronomical, actually. Now, this could be because there's a selection effect, right? People who are already at high risk for suicide are going to psych facilities, so we don't know what the counterfactual is. Maybe the risk for suicide would be even larger. But we do have some reason to suspect, or at least question, that possibly, at least for some people, or at least in some psych facilities, there is iatrogenic harm occurring. And so that maybe some of this increased risk is actually due to their hospitalization itself. And then follow-up rates are pretty low, about 50%. Now, inpatient psych it's a setting, right? Sort of like, it's also like a policy intervention. What is actually occurring within these facilities likely varies greatly, right? And what people experience within these facilities likely is associated with some of these outcomes, right? And so I like to think about what is occurring within the psych facilities, the therapeutic value. I like to think about that as patient-centered care. And the reason for this is because really patient-centered care is about the interpersonal relationships between patients and staff. And that is really foundational for mental health care treatment specifically, right? And then within psychiatric facilities, patient-centered care is even more important because there's pretty huge power imbalances, which I'll go over later in some later slides. And patient-centered care, as I mentioned, is an outcome and is a domain according to the Institute of Medicine. So there's been a lot of mobilization around figuring out how can we improve patient-centeredness? How can we attach financial incentives to improve patient-centeredness? So this is language that the mainstream healthcare stakeholder groups understand. And so I, as a researcher who is studying something that has really been in the shadows, I try really hard to align my work with existing language that is in the mainstream, because that's how we're going to get buy-in and support for improvements, right? So patient-centered care is an outcome. It's also been associated with other outcomes of interest, like safety, effectiveness, efficiency. Now, I'm sure everyone in here has heard about trauma-informed care, and depending on who I'm talking to, sometimes that language can be a little upsetting because people get really frustrated because it's this nebulous concept. And I think this is also kind of a reflection of the different language that we're using in mental health compared to the rest of healthcare. Welcome, Bill. It's all right. I like to think of trauma-informed care actually as a special sort of iteration or expression of patient-centered care that is specific to this patient population. And so there is an evidence-based model for providing care that is trauma-informed, and specifically with regard to preventing and reducing violence, trauma, PTSD acquired from your hospitalization, and the use of restraint and seclusion specifically. And at the center of this is called the 6 core strategies. It's endorsed by SAMHSA as an evidence-based model, and at the center of it is trauma-informed care. And similar to patient-centered care as a concept, it's really focused on addressing issues of power imbalance, shared decision-making, and providing patients with as much autonomy as possible. Okay. Now, when you ask patients, what are the contributors to poor quality of care and harm? They list factors that really are central to the relationship with staff. And we know from research that staff-patient relationships really, that is the most important aspect of care to patients, more important than the relationship with physicians or any other aspect. It's really the relationship with the frontline staff. So all of these actually are the inverse of patient-centered trauma-informed care, right? By explicit violence from staff and patients, threats of violence or punishment, arbitrary rules. And so a story that I like to tell, and it's because I'm sort of stealing this from Kevin Huckshorn, because this is a story that she likes to tell. Kevin Huckshorn is a psychiatric nurse, and she is the one who developed the 6 core strategies. So she tells a story about orange juice. Okay, so you imagine a patient comes out of their room, it's 11 p.m. at night, and they want a glass of orange juice. And so a staff member approaches them. And the staff member may or may not be very pleasant, right? And they say, you can't have orange juice because the rules say that at 10 p.m., all you can have is water. You can't have anything else. And that's the rule. This upsets the patient. So the folks in the room, how many of you get up at 11 p.m., midnight, 1 a.m., and go into the kitchen and get a glass of whatever you want or eat? I do it almost every night, which isn't very healthy. Right? These are freedoms that we're used to having. And imagine you're experiencing maybe potentially one of the worst times of your life. You're maybe have experienced psychosis, suicidality. You are in pain. You are in pain. And potentially comfort is even more important for you in this state. But now you're in this institution and you're being controlled as though you are in a jail or a prison. And so then this interaction between the patient and the staff escalates. And so there's no de-escalation. So there's multiple things happening, and then there's a restraint, right? And that restraint could have been avoided if the policies were different. So that's an example of structural factors at the organizational level that could be changed to be more patient-centered, right? Arbitrary rules. And then the interpersonal aspect, the staff member could have de-escalated the situation also. So these are some quotes. This is from a paper that we have. We have a series of revised and resubmits. And I think that these quotes are pretty powerful. So I'll just read them off. I'll never go back to a mental health facility ever again, even if it means I end up killing myself instead. There's zero trust there. It felt like it's prison. I watched techs or frontline staff who don't necessarily have clinical training bash patients' heads into the ground. They ignored someone who, was maybe in psychosis. And then they go on to share that they do not have access to underwear or clothing for 3 days. This is a population where we can just assume a lot of folks have trauma, potentially sexual abuse trauma. And so this isn't very therapeutic, right? I had a fine experience, but I was saddened by how poorly, less educated, not white, less quote unquote easy patients were treated. So this is really getting at within hospital variation. So likely there are some hospitals that have better culture, providing higher quality of care across the board. But then even within hospitals, there's likely differences in how folks are treated. Okay. So I've been just doing my best to kind of scrape together as much information as possible to just try to motivate the need for improved data, right? So that then we can understand variation to a greater degree and understand nuance better, as well as to motivate quality improvement. It's very difficult to motivate those next steps if you can't even describe what the issues in quality of care are, right? So one approach has been working with complaint data. So for my dissertation, I went through a series of public records requests, obtained a bunch of complaints from 2008 to 2018, and these are mostly regulatory violations. I'm showing this just because I really want to convince you that maybe there's a problem. That's it. I really just want to convince you maybe there's something that we need to look into. So you can see across 11 years, and there's about 65 unique hospitals in any given year, to give you some sense for the scope. Over 2,000 complaints related to physical abuse, over 1,000 related to verbal abuse, and close to 1,000 related to sexual abuse occurring within the psych facilities. These are complaints. And these are formal complaints submitted to the regulatory authority. So it's in, and then there's medical legal death. There's 576 medical legal deaths across the 11 years. Medical legal death, these are deaths that occurred that required the Department of Mental Health to investigate the cause. Then There's some evidence that there's inequities in where patients receive care. So I produced the first analysis looking at this in inpatient psych. This is a question that has been asked in general healthcare. Where are people receiving their care and why? And is it who you are within a hospital that's driving, inequities in quality, or is it where you're sort of being sorted, what hospitals you're going to, and the general quality of care being provided? So what I'm showing you here, this is a graph of predicted probabilities from a fully adjusted regression model where we controlled for anything that was observable. So clinical complexity, there's these special algorithms for that, payments, and this is all payer, this is everyone, including people who actually didn't have insurance, by the way, in Massachusetts. And then geography. So we had the patient's zip code, and so we were able to control also for the distance between where the patient lived and their closest facility, and whether or not that was a low safety or high safety, et cetera. So even when you control for all of that, there's still these residual inequities across racial and ethnic groups. So we created this composite score of low safety versus high safety. The composite score reflects rates of complaints, restraint, and seclusion. And it's the bottom 20% versus the top 20%. So if it was just chance, we would expect all of these to hover around 20%. And where you see deviation, that means there's something else going on that that's not observable, right? So you can see that if anything, white patients have a higher probability of going to a high safety facility, if anything. And then for all other groups, they have a much higher probability of going to a low safety facility. These are facilities with high rates of complaints and restraints. And then there's other factors too, but I'm just giving a general overview here. So some reasons why there might be some issues with inpatient psych. Does anyone want to throw out? I have some answers listed.
And I think one of the things is like the stigma just of that population being like severely mentally ill and people just not treating them like humans.
Yeah, I think definitely. Anyone else? Yeah, Leo.
So there's evidence from some minoritized group that they're reaching the hospital at a much severe condition than non-Hispanic whites.
Yeah.
In a sense, so they're less likely to use services, but when they do receive services, the issues that they're coming in are a much severe level. So there's a lot of other services that are being missed. It doesn't excuse the seclusion and all that stuff and the violence happen, but it's clinically they might be in a different place.
Right, and that's not necessarily being logged by the data, right? Because we control for clinical complexity. There's this algorithm. There's the diagnoses, but still, with psych patients in particular, there's either real risk or perceived risk of violence that I think does drive where people get sorted and the willingness of certain facilities to receive certain patients. So I think that's definitely a factor. So inpatient psych, so you can analyze inpatient psych and there's extreme power imbalances. You can analyze it through different theories, right, in different disciplines. So one discipline that I used recently is economics, and I like to think about inpatient psych through market failures, and thinking about power imbalances through a framework of market failures. The reason being because actually inpatient psych is predominantly a market-based service, believe it or not. It's kind of mixed, but it's predominantly a market-based service. There are extreme market failures, and what that means is that patients don't have easy access to information on quality of care, and even if they did, they can't use that information to shop for care. So there's not a demand response, right? So facilities are not being punished, so to speak, with dollars if they're providing care that's of low quality. And then there's these other factors, like that's an issue, right, for all types of hospital care. But it's exaggerated in inpatient psych because, there's not these other buffers. So for example, family can't easily be at the bedside and patients can't easily advocate for themselves. And fundamentally their perceptions of reality are discredited. And that's unique. It's a struggle that patients have across the board in other settings, but even more severe for psych patients, as you can imagine. And so when you map out these power imbalances, these structural factors, actually we should expect quality of care to be bad. Like actually this should be our a priori expectation. And actually we should be asking for evidence to the contrary. And especially for-profit psychiatric facilities, I'm gonna get into for-profit soon, but in a situation where you have extreme market failures, theoretically, we would expect for-profits to intentionally exploit those market failures to maximize profits. And nonprofits might act like for-profits, but they are more likely to maybe have a little bit of intrinsic motivation, and they have a mission to buffer that sort of profiteering behavior. So in a situation like this, it's really important that we have strong accountability mechanisms to address these market failures, but we don't actually. And in fact, psych patients are excluded from a lot of data sets. So one example being the age caps, which is this national measure of patient experience. 2 patient groups are excluded: if you're dead, if you died, if you have a principal psychiatric diagnosis, right? So not only is the data weak, there's active behavior towards excluding psych patients. And if anything, this is something that needs even more scrutiny, even more accountability. So that's my argument, right? And in fact, there's been advocacy and policies to expand access. We need more psych beds, more. You know, and then there's this narrative that, you know, inpatient psych, it's a money loser, which might be the case, right? In certain areas or within a general hospital, it's a money loser. So we need more money towards the psych hospitals to get rid of the IMD exclusion, et cetera, et cetera. But actually, when you look at the data, inpatient psychiatric beds are becoming increasingly owned by for-profits. And there's been a little bit of decrease in the nonprofits and government owned beds. And these are really large for-profit freestanding systems and chains. So these are big, powerful companies going in and they're opening new facilities. There's some evidence for that. And they're acquiring existing facilities. So they might be acquiring nonprofits, changing to for-profits and acquiring other types of facilities. When I see this, I think, well, someone's making money, right? And someone sees this as an area for investment. So this narrative that this is a service that we're sort of just providing from the goodness of our hearts and everyone's losing money, I just don't think that that's the case, right?
Okay.
Yeah.
In most of these inpatient, this is the way that it's getting paid fee for service, so by the volume, or is it other payment schemes?
That's a really good question. So for Medicare, it's per diem, which basically is like fee for service per day. And there's some adjustments for patient characteristics, but very little. The extent to which like Medicaid programs are innovating, I don't know. I would love to know, actually. Yeah, and I'm meeting with the Missouri Hospital Association soon to see if we can do a study focused on Missouri, but I know that they have been meeting to discuss potential testing of financial incentives for psych facilities. So I think it varies. The role of Medicaid, Medicaid's the largest payer of psych, inpatient psych, and so I don't know how that varies across states. And I think there might be some innovation happening. Yeah. Yes, Phil. Sure.
Did you look at that by rural and urban? Because I hear in rural communities there, and what I've been reading about from a substance use hospitalization side is that it's really a big problem consolidating buying hospitals. There's a trend in rural settings where that may be worse. Are you seeing that happening there?
I haven't looked at that.
Profits or
yeah, no, but that's definitely super interesting next direction. Now when I've looked at differences in complaints, like within Massachusetts, I found that the for-profits actually did have higher rates of complaints for restraint and seclusion, which aligns with the theory, right? And I have some emerging work right now looking at staffing and staff to bed ratios and how that varies across ownership types, and then the relationship between that and quality performance, and then might bring in some union data just to get a sense for the role of unionization and maybe the effect of that. But see, for-profits also have faced a number of investigations for fraud and abuse. And to be honest, I have cited some of this in some news articles and my work, because without really an abundance of literature to substantiate that there's an issue. This is the evidence that I have to use. And so I really do thank journalists for serving as one agent of accountability in producing news coverage that has then led to legal ramifications. So I just want to highlight the heading here: Universal Health Services, large supplier of psych beds in the country. They got in trouble because they were inappropriately admitting people to their facilities, didn't need to be hospitalized, not clinically appropriate, and then they were giving kickbacks to their community partners, right? And this is a phenomenon that we've observed in nursing homes, right? So again, it actually shouldn't be a surprise, but it does challenge the very simple narrative that we need more beds and no one can get care, and it's maybe a little more complex than that. And by just throwing money, you might be making the situation worse without appropriate safeguards and appropriately quality measures, right? So this is one of my first papers on inpatient psych, looked at variation in the Joint Commission quality measures. And these were the precursor measures to the CMS's IPFQR program, which I'm going to describe soon. And all I want you to take away from this is, so these are process-based measures, which mostly don't exist anymore. So CMS has dropped basically all of these measures now. The dark color, that's the for-profits. So when you look at this, the for-profits don't look too bad. And in fact, it's the VAs that look pretty bad. And this is especially true when you look at restraint and seclusion. For-profits look amazing. So if I were just using these data to form my judgments, I might think, oh wow, actually for-profits are doing a great job. Or maybe their business model is they're targeting certain patients who might be, quote unquote, easier to manage, right? And they're not challenged as much in terms of using restraint and seclusion and needing to de-escalate, right? So that's what I might assume from just looking at this. But as I just said, I looked at differences in complaints and restraint and seclusion, and specifically restraint and seclusion that's reported to the regulator and not to CMS. And it's a totally different measure. Okay, so with that said, so in 2013, the Centers for Medicare and Medicaid implemented the IPFQR program. And the measures have been fluctuating. So their first iteration were those Joint Commission measures, and now basically those restraint and seclusion measures are the only ones that remain, and they have a whole bunch of new ones, and they have a good number of claims-based measures. And what's exciting about that is that hospitals are not self-reporting on those. Hospitals are self-reporting on these restraint and seclusion measures. They have different definitions. I talk to people at different hospitals, and some hospitals treat chemical restraint as restraint and some don't. CMS's regulations treat chemical restraint as restraint, for to be clear. Anyways, but there's no measure of patient experience, right? And I'm arguing that patient-centered care is the nucleus, or it should be the nucleus, and from there everything else might flow. Okay, so my thesis is, now I'm going to move on to the study. We need to measure and target patient-centeredness in accountability programs, and it should be considered the nucleus. And then patient-centered care is an outcome in its own right, but it might also be associated with other outcomes of interest, like 30-day follow-up, 7-day follow-up, readmission, etc. And those are outcomes that payers and policymakers really care about. Okay. Any questions? That was the background. Okay. So the aims of the study were to, first, examine the impacts of patient-centered inpatient psychiatric care on changes in patients' trust and their post-discharge engagement with care, their willingness to engage in care. And then 2 was to describe differences in patient-centered care across ownership types, for-profit, nonprofit, government, right? Because I think patient-centered care might actually be getting at the most meaningful part of care, right? And it's much harder to gain. And then explore associations between patient-centered care and facility level quality measures that are being reported to CMS. So this was a retrospective cohort design. It's a retrospective cohort design because recruited people at one point in time on the internet, but was asking them to reflect back and ask them in terms of the outcomes to what extent did the hospitalization change this? And there was some temporal ordering and where I was asking people to kind of reflect back on, right? So recruited folks online, Twitter, Facebook, Reddit. I think actually recruitment from Reddit is amazing. And not that easy. You can't just go into these subreddits and post because you might get banned. So it's actually, I think what I've learned throughout this process is that the internet is just an extension of life, and posting on Reddit is a form of community partnered research. And so I asked the moderators for permission and had to go through that sort of process and then post it in as many subreddits as possible. Administered in this survey, the CAPE measure of patient-centered care. I'm going to share with you the questions that are part of that so you can get a sense of what that's picking up on. And then the outcomes were changes in trust in mental health care providers, changes in willingness to disclose distressing thoughts, changes in willingness to voluntarily go to the hospital, patients' overall assessment on how beneficial the care was, positive, negative, and whether or not they received 30-day follow-up, and that's self-reported. So it's a bit flawed, yeah. And then I operationalized all of the, I ended up dichotomizing everything, just so everyone's aware. So everything's binary when I present the results. So it's yes, no, yes, no. Fit a series of regression models. And then I controlled for a variety of factors, but the one that I really want to highlight is patients' expectations in their care. So I asked them to report to what extent did you expect to receive care that was of high quality and safe. And I wanted to control for that because you can imagine how expectations might color someone's evaluation of their care quality in either direction. But if you have low expectations, you might actually report that your care is much better than maybe someone else would. That also tested the moderating role of voluntary status, because again, you might imagine that the effective patient-centeredness might differ depending on if you were wanted to be there or not. So if you already feel like your experience has been quite coercive, no amount of treating you with respect will undo the impacts of that potentially, or treating you with patient-centered approaches and with respect might actually mitigate against the harm of the original coercive measures. And there is some evidence for that actually in the UK. And then linked responses to facility level characteristics. And the way I did this was I asked patients in the survey, I said, if you can remember, and if you feel comfortable doing this, you share the name of the hospital, the city, and the state. And then we spent a long time, many months, cleaning those data. Most patients did report that information. I don't remember the exact percent, and I apologize for that, but most did. And we were able to link a lot of responses to facility level characteristics. So for-profit, nonprofit government, and then the CMS quality measures. So this is the CAPE measure. We won't spend too much time, and you probably can't really see it if you're in the live audience. But it's just asking, to nurses and mental health counselors, they answered my questions, and it's on a 4-point Likert scale. And so the range, so then I created a summary score, and the range was from 0 to about 69. And then created quartile groups. So the bottom 25%, the next 25, and so on. So we had about 739 valid responses. This is after cleaning for bots and so forth. Most respondents were skewed younger, which makes sense because we recruited online. We had kind of an even split between female and male, and then actually a good number of folks who reported being non-binary or third gender. If I were to do this study again, I would ask more specific questions regarding gender to be able to then look at the experience of trans individuals, or maybe even do a specific study focused on that. And then race and ethnicity was mostly non-Hispanic white, 63%. So not the best data set to then look at racial and ethnic inequities, and so I didn't do that because it wasn't the best approach to do that. Most had less than a college degree, made less than $50,000, and for about a third of the sample, this was their very first time being hospitalized. And so then we control for that too, because if it's your first time, the effects of how you're treated might be even more pronounced. So we wanted to control for that. 68% hospitalized for suicidal ideation or behavior, and then 44% were hospitalized on an involuntary basis. So good variation there. And then this is the variation on the CAPE measure of patient-centered care, which is amazing for two reasons. One, I'm always looking for reasons to have hope in life. And this suggests that there are some folks who are receiving care that they view as being high in patient-centeredness, right? And then from a researcher perspective, this means this is great variation because I'm interested in the effects of patient-centeredness and have this entire spread. It's almost a normal distribution, actually. Okay, just making sure I'm aware of the time. Okay, so this graph, these are predicted probabilities from 4 different regression models. To remind you, so the outcomes are on the bottom, and they're binary. Hospitalization, reduced trust, yes, no. And then the patient-centered care measure, it's in quartiles. And so we have each of the quartiles for each of the outcomes, right? And then predicted probabilities. So the light green is the bottom 25% on patient-centered care, and the dark green is the top 25%. And these are all negative outcomes, so we want the bars to be low. And you can see that there's generally a monotonic relationship in the relationship between patient-centeredness and each of these outcomes. And the largest effects looks to be that the hospitalization decreased willingness to go to the hospital voluntarily. So it's about an 80% probability if you're in the bottom 25%, but then it drops to less than 10% probability if you're in the top 25%. And then we see similar patterns in the inverse. So I've been talking as though like the only possible effects of hospitalization is negative and how we have to mitigate negative stuff. But actually, it can also improve your trust potentially, right? And so we asked about that too. And so for folks who received care from places that were high in patient-centeredness, they had a higher probability of experiencing these positive outcomes too. And this is also true for having a 30-day follow-up visit, right? So the top 25% had about an 80% probability compared to about a 70% probability for those in the bottom 25%. And in general, this is actually overall pretty high rates of 30-day follow-up compared to national average, just to highlight that. And then these are just correlations between ownership and the patient-centered care measure. For-profits had an inverse relationship with patient-centered care, and nonprofits had a positive relationship. And there's no relationship with facility type. And then when we look at the correlations with the CMS quality measures, so I didn't list these measures out before because it takes a long time to say what they are. And I knew that you were going to see this table. But I've grouped them into chart abstracted process measures, which are measures that the hospitals are self-reporting, and then the claims-based measures. And then I have the Cohen's D effect size too, just so that you can have some sense for the size. And I was just so totally shocked actually by all of this, but especially the claims-based measures. The correlations are actually quite strong considering the type of data that this is. So they're in the expected direction. So there's an inverse relationship between 30-day all-cause unplanned readmission at the facility level quality measure, and patient-centered care, and then positive associations with 7 and 30-day follow-up. Restraint and seclusion, we don't see anything. Amazing. Well, if patient-centered, you would think, right, restraint and seclusion is the most proximal to patient-centered care, right? Because patient-centered care is key to evidence-based models to prevent restraint and seclusion specifically. But I am not surprised by this because I actually think that these restraint and seclusion measures are not good. And it's not just, I think, there's some empirical evidence for that. And so this actually just supports what I already thought about those measures. So in summary, reports of patient-centered inpatient psychiatry were associated with changes in trust and willingness to engage in post-discharge care, including self-reported 30-day follow-up. I didn't report this, but the effects were consistent across voluntary and involuntary patients. So there wasn't evidence for a moderating role of voluntary status. For-profits had the lowest reports of patient-centered care, which challenges how they appear in existing publications looking at variation in the national quality measures, especially the process-based measures. The claims-based measures are new-ish. So actually, we haven't really looked at those yet. And then finally, patient-centered care was associated with CMS's facility level quality measures. Right, I just said that. So in conclusion, policymakers and payers should focus on implementing patient-centered care measures systematically. So include a patient experience measure, for example, in the CMS IPFQR program. With systematic data, we can then really tease out, right, within versus between hospital variation. There's all kinds of questions you can ask once you have systematic data. It's really hard to depend on data that you're collecting on the internet from Reddit, right? And then research is needed to figure out how best to motivate and support psych facilities in providing care that is patient-centered. And so that's where sort of my interest in implementation comes in, because that's then the next step after you describe issues. You know, how do we figure out actually improving quality of care? And specifically, what are the policies and financial incentives? And then I just want to throw out, you know, the appropriateness of inpatient psych. I know I've been really focused on reform, but definitely very open to conversations about how to keep people in the community and out of hospitals also. So this, and not everyone likes CFR, but from implementation science, you know, I've learned a little bit from it, and this is how I kind of view my research. And so I'm really interested in these outer setting levers that could then motivate and support leadership's capability to then do all this other stuff within the organization. But in order to do either of these, we need data, right? You can't actually do any of this in the outer setting without data. Hospitals need their own internal quality improvement data infrastructure too, of course. And then next steps, I think I'm doing good on time. So this is just a bunch of words. I know this isn't good presentation practice. I'm sorry, but so the first one is taking this next step to quality improvement. So we're planning to submit an R18 in May to test, well, to pilot/test the effects of financial incentives and feedback of patient experience to improve patient-centered discharge planning. And that's in collaboration with Philly's Medicaid program. And they're very motivated to improve follow-up rates and readmission, right? And so they have money set aside to kind of build out incentives. So we're hoping to do that with them. We'll see. As I mentioned, I'm trying to collaborate with hospitals leadership in Missouri, looking at staffing variation, which I mentioned. Very much interested in understanding crisis response mechanisms that are underpinning the sorting of certain patients to low quality hospitals. And then finally, this is my non-inpatient psych study, implementation of safety planning among 90-day crisis lines. And so that's a small pilot grant that we just submitted with Byron and Danny Adams, who's a postdoc at CMHSR, is playing a pretty big role in that too. And that's my attempt at trying to grow legs in the community and improve the therapeutic value of crisis response in a way that keeps people in the community. So with that, I welcome comments and questions. Yes.
So in that study, did you look at like tease out any impact of the pandemic? So like I'm thinking like maybe people's mental health was worse, or they were more concerned about going into an inpatient setting with the risk of further transmission, or like how that may have impacted any of those outcomes.
Great question. So for that paper specifically, we controlled for whether or not they were hospitalized during the COVID-19 era. But I do have a separate paper that is focused on COVID-19 specifically, because we asked a bunch of questions in the survey about COVID-19 mitigation. So for those who were hospitalized during the COVID-19 era, they received those questions and everyone else didn't. And so, for example, I can just tell you the highlights of our findings from that paper. We were looking at the relationship between use of mitigation activities within these psych facilities, the quantity, and the intensity of them, the relationship between that and patients' reports of whether or not the culture was one that, like an institutional betrayal culture. And then the relationship also between the mitigation activities and patients' fears of getting sick, witnessing other people getting sick, and what else? Maybe trust, maybe we look at trust as well. And we find a relationship, and it's monotonic in the same way as patient-centered care in terms of the mitigation activities, just really interesting. And I think that what that's picking up on is actually a shared underlying construct of culture. Not that the mitigation activities caused people's perceptions of an institutional betrayal culture or other things, but that hospitals that already had kind of a culture that was responsive to patients were more likely to implement mitigation activities, and facilities that already had a culture of betrayal were less likely, is what I think is happening there. We don't know. Yes.
Hi, my name is Maya. I'm an Bio student.
Nice to meet you.
Nice to meet you. I have a little bit of experience with patient quality care with IHI, predominantly in pediatrics, so it's really interesting to hear you talk about inpatient psychiatry. Did you guys, for your participants, did you ask them if they've had any previous experience with like the hospitals, or like if their families, or like if they had heard about like their family member having any experience with hospitals?
Yeah, great question. We asked if they had been hospitalized before, so and so about a third had never been hospitalized before, but a good number had been hospitalized repeatedly. Did not ask them questions about those experiences, just trying to keep it manageable so that it was a really long survey. But I think that what maybe you're getting at is the extent to which prior knowledge or insight colors your expectations, and I think that's a really interesting avenue for future inquiry, and possibly a good fit for like maybe in-depth interviews. Yeah.
Thank you.
Yes, Leo.
So I thought it's some fascinating work, Morgan, and think very interesting how you're moving through all these methods and understanding this research question from different perspectives. I think that's really cool. I guess I'm reacting to two things. One, that in mental health services research, one of the outcomes is not to get people into the hospital.
I know, yes.
Everyone is making sure that you don't go to the hospital.
Yeah.
Right? That's a major outcome.
Yeah.
Yet we haven't asked the question, and you're asking, okay, well, people will have to go to the hospital. Let's make sure that hospital
Yes.
there is good. So in patient-centered, I think it's a great concept of figuring out quality. I guess what I'm struggling with is in other patient-centered elements, in chronic disease or other one, it's related to like the type of practice that you should get. So I guess it's how is that measure that you have of patient-centered care related to the type of care that you should, like what is the, I guess it's what is high quality inpatient psychiatric care?
Yeah, no, it's a great question. Well, to be honest, I'm not sure I can answer that. Because it requires us having agreement on what we think the outcomes of inpatient psych should be. So is it just a place for stabilization, or is it a place where there should be some sort of improvements, a clinical improvement, and to what extent is it reasonable to expect like how much improvement? And I don't think that there's actual agreement on what the role of inpatient psychiatry is in society. So I really struggle with this. And that's also why I don't touch effectiveness. Right. And that's also why I'm really focused on patient-centeredness, because for a variety of reasons. I mean, the main reason actually is because I think there's an issue with how people are treated in a very dehumanizing way, and patient-centered care is just a way to conceptualize the inverse of that. But also because it's like regardless of the medications or regardless of the specific treatments, you can deliver whatever that is in a patient-centered way. And so that's what the measure asks, did you have a say in the medications you were given? Did you have a say in your discharge plan? So the questions are about the role of the patient in the treatment decision-making, but it doesn't get at what the actual treatments are.
But it's related in your paper, if I understood that correctly, it's related to some really interesting quality indicators.
Yes.
Like it's related to cardiometabolic screening, which is a weird sort of relationship.
It's weird.
But it makes sense because, patient-centered care is about taking the whole person.
Yes.
So it's interesting that there's a positive relationship between you have that experience, but you're also being taken care of for physical health. tobacco use, that was really
That-
fascinating
Yeah,
to see that.
Yeah.
That's my area, so I'm picking up a part of that. But I guess it's, yeah, I guess it's trying to link about patient-centered care and the effectiveness of what is a good inpatient care unit. Like there has to be some good evaluation. So these are all acute. There's an acute component, so how to mitigate the acuteness. And then I think you're completely right, which is where things are falling apart. If you have a lot of inpatient care, there should be a discharge plan that really connects the person to care. So there's some follow-up to that. That's a major component. And if you're seeing low patient-centered care, lack of follow-up, and then there's an area there to improve.
I mean, there's an argument for, okay, what's the role of inpatient psych in society? And the way it's functioning right now, if the role maybe is stabilization, and then it should be to connect people to services, right? If anything, you have someone who's in crisis, if there's any role that inpatient psych should be serving, I would argue it should be to then connect them with the appropriate supports in the community.
And make adjustment to the treatment, something may be going wrong, the person might not be, there might be issues with, problem with treatment, or not receiving treatment at all.
Yeah,
But I think that's correct, the connection to care in the community, that's the linkage.
Yeah.
And that actually is a window of opportunity for connecting that person. If you have a bad experience at the hospital and it's not linked to good experiences outside, you're leaving these people
Yeah.
sort of left in the ether of how to.
it can generalize, and I'll say that, I mean, so institutional betrayal is a concept from psychology, and it is kind of like the other coin to patient-centered care, but not exactly. And there's been some work to look at the relationship between patients, this is outside of inpatients, like the patient's experience of the betrayal, and how that impacts their trust, and then their future long-term cascading engagement with care, and then actual health outcomes. And there is some evidence that in just general healthcare, not even inpatient psych, that it does, mediated in part through trust, reduce patients' willingness to engage in care moving forward. And it has consequences.
Got a question online.
Oh, there.
Or just Joe is raising.
Yeah, Joe, you're raising your hand.
Go ahead and speak.
Hi, my name is Joe Curlo.
Joe.
I'm the clinical manager for Lutheran General Hospital for the Inpatient Behavioral Health Unit. First of all, thank you for presenting, because there's ostensibly a lack of research in this particular area. But also I wanted to see
You
if
can put it in the chat.
Yeah, let me see that.
yeah, I was wondering if in your research
And actually do that, well, I think the other piece that you're getting at is the financial incentives.
Yeah,
This is a fee for service. That's the structural incentive to keep people churning in. It's fee for service, so more people in the hospital, more things. The system is set up for that type of thing, and regardless of the experience. So I think the work that you're thinking of financial incentives to link that to patient-centered care and quality, it's a great leverage to improve care here. Can be done.
Is Joe trying to go on and off mute? Because I don't know.
Oh, yeah.
Oh,
That's good.
Because that would tell us if it's
no, we're not. No, they're not.
No.
They're not being heard. So, can you put questions in the chat? Okay, great. I think medication adjustment though is a whole other
Do what, I'm sorry?
medications.
Uh-huh.
So I mean, like a pushback that some psych facilities might have is, well, we don't actually have enough time to be able to appropriately adjust medications and look for the effects that they have on patients, and yeah. Okay. So I don't, it's a great question. I don't know who's doing this right. You know, there are some alternative models to crisis response that are community-based. And I think that those are worth us seriously considering, a better supporting. Because there is a question of, is there something inherent about an institutional setting that no matter what you do, is it always going to sort of, to a certain extent, devolve? And there is a coercive nature to inpatient psych. So you can only reach patient-centeredness to a certain degree. So I don't know who's doing it right, but I do think that there are some promising community-based models for keeping people in the community who are in crisis. And then I'm not aware of any research on acuity segregation and its relationship with patient-centered care specifically. I'm actually not aware of a lot of research on patient-centered care in inpatient psych to begin with. Yes, well, yeah, you know, to be frank, so first of all, I'm not a clinician, I don't have clinical experience. My partner is a clinician and complains a lot about the Joint Commission. And I think that the Joint Commission's hyper focus on safety, to be quite honest, an unintended consequence is really that facilities are very much focused on physical safety. And it sort of becomes like a jail or prison, like there's strip searches and you can't have access to anything. And some of that is worthwhile, like access to literature points, but it comes at a cost. And without any sort of counter to that, like focused on emotional safety or, you know, therapeutic value, it does become sort of a containment tank, so to speak, that is very much just focused on physical safety. And I think it can undermine therapeutic value. So that's my thoughts on the Joint Commission, very briefly. The CMS requirements are also not really, you know, I think that there's a lot of opportunity for improvement within our accountability mechanisms, definitely. And an opportunity for frontline staff in particular to play a role perhaps in improving those mechanisms for sure. Any last burning questions?
Just say, I know we're at the top of the hour. If you can hear this, and for folks in the room, our next and I believe last seminar of the year will be on May 3rd from 4 to 5. And Dr. Gretchen Buchanan will be presenting practice-based implementation strategies for integrating behavioral health and primary care, preliminary results from a pilot study. So we'd love to see you all there, whether in person or online. Thank you so much, Dr. Shields.